So the angiosome, fact or fiction, I wanted to take you through what it is and then also introduce to you some basic concepts of perforator flap anatomy. I have no disclosures. So the angiosome concept was first introduced by Ian Taylor, my mentor, and John Palmer some 40 years ago in 1987. It was used as a concept to understand the blood supply of tissue, and hopefully this morning I'll be able to take you through that concept in some detail. We all know that blood vessels emerge from the deep fascia to spread out and supply the overlying tissue, and that they tend to do it in this characteristic tree-like or branching pattern. An angiosome, in its most basic form, is that three-dimensional block of tissue that an individual perforator or a blood vessel supplies. This block of tissue, Ian and John called an angiosome. This is one of my patients. This is a Dieppe flap, and we can see a three-dimensional block of tissue comprising fat and skin from the lower abdomen, and it's supplied by the deep inferior epigastric artery and vein. And so this block of tissue would be called an angiosome of the deep inferior epigastric artery. Why is this concept important? It's important because it helps us understand why tissue lives and why it dies. These are some of the patients from Ian's original studies back in the 1980s that led him to come up with this concept. And we can see here, if I get the cursor to work, why is it that we have two flaps on the lower leg of the same patient that were raised by the same surgeon at the same time, and one of these flaps completely lives, the other flap completely dies? Or another head and neck patient who's having a deltopectoral flap, we can see that on one side, the flap has died halfway along, and on the other side, it survived right to its tip. Now, initially we thought that this was because if you made flaps wider, they would be more reliable, and flaps died because they were too skinny. And that was comprehensively proven to be untrue by this British plastic surgeon, Stuart Milton. And in this very elegant experiment on the side of a pig, he raised a flap which was 16 centimetres wide and another one that was 2 centimetres wide. And you can see both of the flaps die at exactly the same spot. Therefore, whether a flap lives or dies is not dependent upon how wide that flap is, but on its intrinsic vascular anatomy. And so there, if you know what the intrinsic vascular anatomy is, you can predict whether your flaps are going to live or die. This work conducted in our lab some 15 years ago, and it looks at the blood supply of the superficial temporal artery in a 20-week-old fetus, a 28-week-old fetus, and an 80-year-old woman. And if you have a look, you can see that the template, the vascular architecture of the superficial temporal artery is exactly the same in all of those three specimens, those three studies, meaning that the basic template of the blood supply of the body is laid down very early and it doesn't change. Further, this is work conducted by Ian and Toshi Minobi, and you can see that the superficial temporal artery in the human, the monkey, the pig, and the rabbit is almost identical. The only thing that is different is the function of the tissue that is being supplied by that artery. So where you have an appendage such as a long ear, then the corresponding superficial temporal artery becomes bigger. But the template between these four animals is exactly the same. So let's go back to basic soft tissue anatomy, because this is going to help us, I think, understand things a little further. We know that the integument, that is the soft tissue above the deep fascia, is composed of 5 layers. So we have 5 tissues. Layer 1 is the skin and dermis. Layer 2 is the fat immediately underneath the dermis. Layer 3 is usually a fascia, such as Scarpa's fascia in the abdomen, but it can be the SMAS musculature in the face, it can be the dartos fascia in the scrotum, and so forth. So layer 3 changes a little bit. Layer 4 binds layers 1, 2, and 3, 1, 2, and 3, which are tightly bound together. And layer 4 binds these 3 layers to layer 5, which is either periosteum or deep fascia. And blood vessels, nerves, and lymphatics emerge from layer 5 to supply the overlying soft tissue. That makes sense. What's important to realize is that they do so in a close association with the ligaments, which are binding layer 5 to those fused layers 1, 2, and 3. So these ligaments binding layers 1, 2, and 3 to layer 5. And therefore, wherever you see a ligament, you also see lymphatics, arteries, and veins. We know that layer 4 is variable in that it may rigidly fix layer 3 to layer 5, like this, where you can see it is rigidly binding everything together. And this would be analogous to the sole of the foot or the palm of the hand. Or there may be a gap and the ligaments and the vessels are widely spaced apart, like this, where you can see that 1, 2, and 3 are still tightly bound together, but there's a gap in between the ligaments binding the layers together. And this gap may be filled with loose areolar tissue, as in this case here, or a bursa, as in this case here. Why? Well, the answer is because of mobility. If you think about it, if you want these layers all to be stuck together and act as one, as you do in the sole of the foot, you don't want your sole of your foot slipping and sliding around, then these are going to be rigidly bound together. But if you've got an area which needs to move, such as if layer 3 is composed of a muscle, say as in the face, then it's got to move. And if it's got to move, then you can't have a ligament there because it's going to stop movement. So if we take this then, say, into the chest and the breast, we have pectoralis major. It's got to move, so the ligaments must be at the edges of pectoralis major. So here we have the internal mammary artery and the perforators emerging at the medial border of pectoralis major and then coursing up into the overlying breast. Out laterally, there's no pectoralis major. And so the branches of the lateral thoracic artery come through at multiple levels through multiple ligaments and course directly towards the nipple. And when we do an angiogram study of the breast, that's in fact what we see. Here's the internal mammary artery perforator coursing over towards the nipple versus the lateral thoracic perforators going directly through the breast to reach the same nipple. So the movement of that tissue directly influences the vascular architecture or the vascular pattern. And therefore, perforating vessels emerging through layer 5 may be closely spaced together or widely spaced apart, as we talked about, closely spaced together or widely spaced apart because the ligaments are closely spaced together or widely spaced apart. And I use this analogy where you can have lots of small trees, lots of small blood vessels grouped together, or you can have isolated trees which are of much larger caliber, widely spaced apart. We know that the important communicating structures, nerves, arteries, lymphatic and veins, all use the ligaments for support, as we discussed before. And so the geographical arrangement of the ligaments determines the location of the perforators. And in a simple system, this determines how much of your flap will survive. This is a study done on a dog by Ian Taylor at the time of the angiosome concept. And we can see here is a central perforator. And on the dog, we have raised a trilobed or three-lobed flap. And we can see the difference between the perforators, location of the perforators is different in each one of those three lobes. So this is a blow up of this one. And we can see here's the central perforator. And we can see that the flap dies just after the closest perforator. So if the closest perforator is relatively short, it's relatively small distance away, then the length of the flap that survives is relatively short here and here, and the tissue beyond that is dying. Whereas if the perforator is a long distance away, and in particular, if it's located at the tip of your flap, then all that tissue will survive. So, as we said before, each perforator has its own three-dimensional block of tissue that it survives, and Ian Taylor called this an angiosome. It's important to realize that this block of tissue can be composed of anything. It can be composed of fat, skin, bone, muscle, nerve, whatever that particular artery and vein is supplying. And we said before that there's two types of angiosomes. There are those angiosomes or perforators which are closely bunched together, and there are angiosomes which are widely spaced apart. We then went on to develop a concept called the functional angiosome, and I want to spend a little bit of time, if I can, today explaining that for you. So the functional angiosome, this is available in this paper. We published this in 2013. It's on PRS, and it goes through the concept which I'm going to talk about now. So remember we talked about two different types of angiosomes, ones like this and ones like this. And what the functional angiosome does is it goes to investigate and talk about the communication between these angiosomes, the communication between these perforating blood vessels. And we know that this vascular connection can either be by two types of vessels. Sorry about the clock. It can either be by a true anastomosis or by a choke anastomosis. So the top vessel here would be example of a choke anastomosis. By that I mean that the two perforating arteries or angiosomes are interconnected by reduced caliber capillary-like vessels here, versus a true anastomosis. The vessels are effectively acting like a true anastomosis. That is, they don't decrease in size and truly connect the two perforating vessels as if they were one. So a cadaver study that I did 2 years ago, just showing the difference between the two. This is the angular artery and the dorsal nasal artery. This is an example of choke anastomoses. Same vessels interconnected now by a true anastomosis. And if we look at another lead oxide study, we can see here's another example. So here would be a choke anastomosis interconnecting this perforating vessel with this perforator. And here's a series of true anastomoses interconnecting these three vessels together. And therefore, they're going to act as if they were one, because there's no restriction in blood flow between the perforators. Now, we know that these perforators act differently. So this is a study where we looked at the skin and we cooled it down with one of those athletic sports packs, one of those ice packs that you put in the fridge when you sprain your ankle. Cooled the skin down to 0 degrees. And then with thermography, that's an infrared camera that measures temperature, we measured how quickly the skin rewarmed, how quickly it reheated. And we can see that there was two distinct patterns, that the choke anastomoses, the rate of rewarming was very slow, whereas with a true anastomosis, there's a rapid rewarming of tissue. The analogy would be that a true anastomosis is like a freeway between two perforators, and a choke anastomosis is like a country back road between perforators. And when we look at a study, say in the leg, this helps us understand why the leg is so precarious. Here we can see that we've chilled the back of the leg down to about 15 degrees. And you can see here that therefore the whole of the leg is this blue color. We take the cold pack away and then we take a series of photos with this infrared camera. As the warm blood comes from deep in the fascia out into the overlying tissue, it's going to rewarm that tissue, and so it allows us to see the function of the individual interconnections. And we can see here the individual perforators, which I've highlighted as black. And we can see that the bottom perforators are interconnected by true anastomoses, but the top perforator is connected by a choke anastomoses. And when we look at a lead oxide study, we can see that, in fact, that's exactly the same. A running line of true anastomoses and a series of choke anastomoses at the top. The functional importance of this is that if you raise this flap on any one of these perforators, the whole flap will survive because it's functionally acting as if it were one. Whereas this perforator is different and it's connected by choke anastomoses, and hence raising this flap on this perforator is actually more risky, more precarious than raising it on the bottom flap. So counterintuitively, in this particular person, raising the flap distally is safer than raising it proximally. And we can find this information out ahead of time. So this is a thermal camera, which most of you, I think, might have heard of now, called FLIR, F-L-I-R. And it's a camera where you can do the same thing. You chill the tissue down, and then you look at how it reheats, and it tells you what tissue is going to survive and what's going to die. This is the CT angiogram of this lower abdomen. This is the thermal image when both these two perforators are allowed to run and are perfusing the tissue. And as before, you can see there are perforators that are connected by true anastomoses, and there are perforators that are connected by choke anastomoses. Now, what we're going to do is I'm just going to put a clamp on this perforator here. And when I do that, you see the tissue that is connected to the main perforator, to the remaining perforator by choke anastomoses, loses its perfusion and cools down. The clinical outcome of this, therefore, is that this tissue would die if we raised it on this perforator. And we can predict that before we raise the flap. It also explains why the original study of Ian back in 1970 as to why this flap lives and this flap dies. This flap is interconnected by true anastomoses. This flap is interconnected by choke anastomoses. So how much tissue you can safely raise depends upon the distance between perforators and the interconnections between those perforators. There are two additional critically important concepts. The first is the law of equilibrium. And what I mean by that is that if you have a system, there will always be one dominant perforator, and on the opposite side, the corresponding counterpart will be small, and then the other system will be necessarily large, and its counterpart will be small. So here we have a large perforator emerging from the left rectus abdominis, minuscule, virtually no perforators on the right-hand side. But we have a very large superficial system on the right-hand side and a very small superficial system on the left-hand side. So that's big, small, but because that's small, that's big. Because that's big, that's small. So there's a balance. Now, where that's most obvious is those of you who raise ALT flaps will know that sometimes the perforators for the ALT flap are very small. But if you extend your dissection medially, you'll note that the AMT, the anteromedial flap will have much, much bigger perforators, and you can safely raise it on that flap. Or the TFL flap will also be large. So if your ALT flap perforators are small, your TFL and your AMT perforators will necessarily be bigger. The law of equilibrium. The second is the process called delay. And what this is a process where we can convert choke anastomoses to true anastomoses. It's a permanent change and it takes 3 days to occur, but is absolutely complete by a week. It's a very valuable tool because it allows us to harvest tissue that otherwise we would not be able to. So this is one of my patients last year. She has a total mastectomy in the past, and she wants to have a DF flap. She's got a small amount of tissue here and not a lot of tissue anywhere else. And when we did her CT angiogram, what we found was that all her perforators were small. All of them were under 1 millimeter, so not ideal. And there were lots of them. So she had that analogy, she had that image that we talked about before of the multiple perforators emerging through the deep fascia rather than single perforators widely spaced apart. So this is not someone that you want to do a DF flap on. So what we did is we took her to theatre before surgery, before our definitive surgery. So we took her to theatre 1 week before our definitive surgery, and we raised all the tissue around these perforators, leaving these 2 skin bridges on the edge, but undermining everything else back to those 2 perforators that we identified here. Just 2 because I wanted to be safe. And we come back here, we close that up. So that's her immediately afterwards. That's her at a week after surgery. And we did another CT angiogram. And what we can see is this perforator has now dramatically enlarged and is now 1.6 millimeters in size. So here's that perforator before, and here's this perforator after. And we can see where that perforator is because we can use thermography again. This is me before I'm about to transfer the flap. And you can see that here's the true anastomoses now interconnecting this flap. It allows us to transfer the entire volume of that lower abdomen on one single perforator. And on looking on the thermography, we can see that there is complete perfusion of all of the flap, and therefore the flap goes on to heal uneventfully. So thank you very much. I hope this makes sense. Obviously, I'll be available to answer any questions you may have. But I trust that you would understand that an understanding of the angiosome concept is critical to microsurgery. And if you're able to employ both the angiosome concept and the delay phenomenon, I think you'll be able to have much more reliable and predictable free flap surgery. Thank you.